It's been kind of fun over the last little bit of time to try to wrap my mind around an area that I'm passionate about and discover how we within the Nemours system can contribute. Um, and this is going to be fairly basic and high level, lots more work to do. But really, the topic is pediatric cochlear implantation using our enterprise to access access and outcomes within this space. In my role as a Ginsberg-sponsored MRDA scholar, Dr. Peter Beniski has been my mentor, and Lindsay Addisey has been a very close collaborator. I'm also looking to collaborate with surgeons and one sociologist or social worker here in Central Florida that bring the Nemours sites in Wilmington, Jacksonville, Pensacola, and Orlando together. And so by way of background, for deaf children, spoken language development, it really is borders on almost miraculous, right? It's just so hard to achieve. But cochlear implantation and restoring near normal levels of hearing to children has changed that. And if provided early, offers an opportunity for children to develop skills that can really mirror closely their normal hearing peers. Unfortunately, we know that there are differences in access that certain children have to this technology, and there are differences in the time and length of deafness that children experience. And that, of course, can result in some variations in their outcomes, particularly from a spoken language perspective. And while that is understood if there's a child who's developmentally delayed or has multiple comorbidities, for children who are otherwise cognitive appropriate, that can be perplexing. And so what we kind of how we've set this up is to look at this in two phases, two projects kind of within one. Um, Perhaps a bit ambitious, but the first is related to the second, and that is we wanted to look at timing to technology and access to technology. And we know that timing and access to technology is an important part of outcome. And so the first part is really looking at our timing and access, and then the second part with which we are looking to submit a grant would be outcomes. We know that there's a critical period of language development and brain development, really that birth to three age is where that neuroplasticity is most adaptive and really important for building those fundamental skills. We know that there are differences based on sociodemographics such as race, ethnicity, and insurance, and we've shared that based on some work we did here in the state of Florida in a couple of different projects. And in the project we looked at, it actually looked like while insurance was strongly relevant, ethnicity and race was more, and that was a bit surprising. What we don't know is if specifically we see some of these disparities in our northern Florida Panhandle, and in the Delaware River Valley region, or is this just something that we've seen in Central Florida? And we don't know what is the hierarchy of importance, which of those factors is the most impactful in those particular geographic regions. In thinking through what are some opportunities that could be creating and contributing to these factors, the idea of transportation and food insecurity were areas that we know have relevance in other pediatric health metrics. And so we were wondering, can we get at that and see if those actually serve as proxies for a story that needs to be told? When we think about a project of this nature, certainly understanding what is keeping the diffusion and adaptation of technology has benefits in the quality of care and in the outcome that's secondarily achieved. Understanding which factors are most important and most modifiable also would set us up to have some testable hypothesis for things that we might be able to do in the healthcare sphere that could potentially move the needle in the correct direction or a more ideal direction. And so what we said we would like to do is kind of just go through a few of the unknowns to see if we can add to that information. And so determining, first of all, if there are differences and disparities in timing to implantation outside of the Central Florida region, which we already know do exist. So North Florida, Florida Panhandle, and the Delaware Valley. Then we wanted to determine some of the characteristics that were related to that that we see in those disparities, if they exist in those markets. We wanted to determine which factors had the most relevance and seemed to, in our regression model, explain the most amount of variation that's there. Determine if there are insecurities from food, if there are challenges with transportation in these areas, and then see if there's a relation to explain that across the sites. And so again, this is kind of restating what our objectives were in a way that asks questions. Now, in focusing on the access and timing to implantation, that sets us up to then ask the perhaps more interesting question, which is, well, does that matter? Do we see differences in how these children are developing spoken language skills? And so do speech and language outcomes differ based in these particular areas? That's a little bit more involved than just asking at what time period did a child receive a operation. Do we see differences in those speech outcomes based on geographic areas, based on some of the social determinants of health that we know exist and can color pediatric healthcare? Is there a predictable relationship to which variables seem to have a more consistent relationship with others that would allow us to really offer some degree of predictability in what we would expect? Again, this would allow a chance to develop a testable hypothesis in terms of intervention, right? So the first part of the study is really just a retrospective case series, pulling data from the Nemours data warehouse. Our eligibility criteria, we had to kind of try to be as tight and consistent as possible. So children who have bilateral severe to profound sensorineural hearing loss, who underwent operations at one of our facilities or facilities that we're closely affiliated with over a 10-year time period, excluding children who have only unilateral hearing loss or single-sided deafness, those who were implanted at a non-Nemours facility that may have then transitioned to be followed by our team, children who were older than 5 years of age, and children whose cause for hearing loss was related to either trauma or infection. You know, those can cause some anatomic issues that might, in theory, compromise the quality of signal that's then presented to the brain. In our initial query, just getting an idea of how many children could potentially be in this group, you'll see the numbers listed here, a little shy of 500, with distribution across the sites. Of course, and not surprisingly, our Pensacola market is the smallest, and we'll just have to see what we gain from there. You know, it does add a neat aspect of its rurality, which is certainly a factor to consider when it comes to pediatric care. And so the outcomes or the dependent variables we are looking at are going to be intervals and really ages of intervention, right? So what is the time from identification to diagnosis? And then what is the time from diagnosis to intervention, right? And so by looking at our audiologic records, our otolaryngology records, seeing when a child failed a newborn hearing testing and when did they then have that definitive identification by audiologist, when did they then after that receive a cochlear implant are important time periods. We'll look at what was the first side done and if there was a second side or it was done simultaneously. You'll see the categories of ages that are distributed here, providing us a really kind of four groups. And our independent variables that we were looking at, just so that we can try to compare apples to apples, are going to get at our etiology of deafness. The lion's share is expected to be genetic or perhaps unknown, because we don't always have positive genetic testing done. Anatomic, whether it's related to a CMV virus, you'll see the medical histories that we will be looking at. I'm going to skip the indices and come back, and then you'll see the list of our social demographic factors that we are planning to collect in these areas. All of these variables, perhaps maybe with the exception of county of residence, have been really affiliated with some factor in terms of how care is achieved for children with sensory or hearing loss and cochlear implantation. An area that Dr. Minsky's team will be particularly helpful for me in is the area of the indices, with the social vulnerability index, the area deprivation index, and the child opportunity index. I have not spent a lot of time with those, and I'm looking to learn more and get more familiar with them. And some of those are going to probably be the closest we may get to really getting at some of those food insecurity and transportation challenges that we really would like to explore. So that's kind of a high-level overview about the project. In terms of so our strategy really is to kind of do that first part, our first portion first. We have an IRB pending and cooking, so we can pull that data and move forward in that regard. The thinking now is to then use the question with regards to speech and language outcomes more as a fundable mechanism. That's going to be a bit more involved. Will take a bit more creative analysis and be certainly more time consuming to pull that together. And so that's what I'm looking to write for, with the simplified aims of determining if speech and language outcomes really do differ across geographically different sites that are reflected in the locations that Nemours centers serve, allowing us to compare the rate at which these children are acquiring their skill and the percentage of children who have age-appropriate skills by the time they enter that kindergarten or first grade age. And then secondarily, determining if there are differences that have a predictable relationship, and would allow us to explore with modeling and manipulation what we would expect of a particular child who presents for these operations. And I think that's it there. So thanks for the chance to share some of the thoughts as we're trying to work towards, an area of research that that I believe has value as we navigate resources and health professional shortages in ways that could really challenge optimal development for the children we serve.